Dr. Cohn is joining us from Toronto, Canada, and he is going to be named the chairman of the pediatrics department this summer. He is a long-term investigator, or long-time investigator in the neuromuscular field, and has a particular focus on the muscular dystrophies, both Duchenne muscular dystrophy and congenital muscular dystrophy. And Dr. Cohn and I ran a scientific meeting for LAMA2 CMD this February in Toronto, where we invited several, about somewhere around 30 people, international scientists, clinicians, to attend this meeting and provide us with updates on the research that they are currently performing in their laboratory or clinical research that they've performed. So this webinar today is an update on the highlights from that meeting and an opportunity for you to get to meet Dr. Cohn and learn a little bit more about the research that he's currently performing. Without further ado, let me get started. I'd first like to share with you some data on total numbers of people in the registry, the Congenital Muscle Disease International Registry, and then specifically numbers on LAMA2 CMD. So as you can see, we're almost up to 2,000 registrants from 72 countries. And the majority of registrants are in English-speaking countries because this registry was initially launched in English, though it is accessible to people who speak other languages through using Google Translate as an option. This is really a huge project and a big investment of Cure CMDs, and there are several people on this call who have been working tirelessly and volunteering their time in order to improve and increase the numbers of registrants and the data that we have in the registry. This registry is starting to make the CMDs more attractive to the pharmaceutical sector because we're starting to get a better sense of how many people are immediately available for clinical trials. So when you break down the total number of people in the registry, we fall into three main bucket categories: the congenital myopathies, which represent about 1/3 of the registrants, the congenital muscular dystrophies, which represent about 1/3 of the registrants, and then kind of a smorgasbord of other congenital and limb-girdle onset patients, as well as people who were not actually sure what they have, but they felt that they belonged in this registry. And part of the reason why we're not sure what they have is because they may have only completed the demographic questions and not provided us with any details about the disorder that the affected individual has. So there was recently in 2014 a publication that came out of Italy where they reassessed the prevalence. So how many people are there with congenital muscular dystrophy in Italy that have been genetically diagnosed? And when we apply their numbers to the United States as just one example, you can see that for LAMA2 CMD, one would expect to have at least 433 people with LAMA2 CMD in the United States. However, only 90 people have registered. Okay, and this is the same for the top kind of countries where people have registered in terms of the population of that country. So you can see that we still have a tremendous amount of work to do to not only identify people who have the disorder, ensure that they have access to genetic testing, but then also get them registered so that we can slowly increase our numbers and have the types of numbers that are needed in order to conceive of running a clinical trial. This estimate may or may not be totally accurate. The Italians have long provided fantastic neuromuscular care, and we're not sure whether the prevalence that one finds in Italy is exactly the same in other countries, but at least it's a good starting point. And so with these numbers, we can basically start to reference how well we are doing at capturing the expected population in countries that have registered. So in total registrants, we have around 212 registrants with LAMA2 CMD. You can see the majority of individuals are under the age of 20 to 25. It's equally split between male and female, and the majority of people who are registered are living. We do also encourage people to register affected individuals who have deceased, because again, this allows us to better estimate the global prevalence of LAMA2 CMD and better understand the age at which individuals may experience greater challenges to their health. When you look at the total number who are able to walk, you can see that 7 people have not reported to us what their ability to walk status is. The majority of people with LAMA2 who are registered have never been able to achieve walking. Some were able to walk in the past and lost it, and some are still ambulant or are walking. And this pretty much jives with the reported literature showing that the majority of people with a mutation in LAMA2, in the LAMA2 gene, do not acquire the ability to walk. And this becomes very important to us when we start to think about running clinical trials, because most clinical trials for people with a neuromuscular condition or muscular dystrophy have focused on endpoints that assess walking ability. But as you can see, for LAMA2 CMD, this may not be an endpoint that we can use for a clinical trial to determine whether or not a drug is effective. When you look at breathing support, and this specifically means either BiPAP, so non-invasive ventilation, or a ventilator with a tracheostomy, you can see that 122 currently are not using any breathing support. And when you look at the ages, the majority of individuals are under the age of 10 to 15. And that may help explain why a large percentage of individuals with LAMA2 CMD are currently not using breathing support. Then the next biggest category are those who use breathing support at night. And then you can see that there are some individuals, and we haven't correlated this with age, who are starting to require breathing support during the day as well. In terms of G-tubes, which is another consideration in LAMA2 CMD from a health standpoint, 66 have reported not ever having a G-tube, 46 currently use a G-tube, 4 have used it in the past, and then from 96 individuals we have not received a reply, and thus we don't know what their G-tube status is. And then, as many of you know, a certain percentage of individuals with LAMA2 CMD may develop a seizure disorder, and this has been reported in 11% of individuals who are registered. The literature cites that anywhere between 8 and 30% of individuals with LAMA2 CMD will develop a seizure disorder, and so this is right in line with those numbers, although on the lower side, which of course may in part be reflected again by the fact that the majority of registrants are on the younger side, and most who develop a seizure disorder may develop it anywhere between the ages of 8 and 20. And so again, that may reflect just the age range of people who are currently registered. Any questions so far on the CMDIR data?
This is Mark from California. Can you hear me?
Yes.
Okay, good, finally. Yeah, I was just wondering, with the numbers you took from Italy and then tried to broadcast them across other countries in the world, it's my understanding that the origins of this came back from Europe. So would it be feasible to expect that the density of, like the frequency of LAMA2 would be higher in Europe than in the US, or is that a misunderstanding on my part?
It has been always stated in the literature that that people felt that in Caucasian populations the incidence of LAMA2 CMD may be higher. But what we've noticed is that LAMA2 CMD is actually quite prevalent in China, and though not very prevalent in Japan. So there may be some populations where we see a higher prevalence or a higher frequency of mutations, and we're not sure whether there are in fact founder mutations, because those have not really been described before for LAMA2 CMD, where, for example, there is a certain mutation that is commonly found in one country and that there are a certain number of people who carry this mutation. So I think the honest answer is that in many of the most populous countries of the world, such as China and Italy, genetic testing has only recently become available. And so it is unclear whether the prevalence patterns that we see in Europe are equally reflected in the United States, Canada, and then any other country, including countries such as China and India or Brazil or South America.
Okay. I've just seen different frequency numbers. Of one study I saw said it was 1 in 30,000 people were diagnosed with LAMA2, and this looks like it's 1 in 200,000 people. I guess at this point in time it's just very unknown because of the frequency in which it's diagnosed is quite low because of genetic testing.
That's exactly right. And what we're hopeful is that as access to genetic testing becomes more available, that we will start to have more accurate numbers. But then again, we do need people to register in order to get a better sense of accurate numbers. So it's two things need to happen. We need to have access to genetic testing. Genetic testing needs to be encouraged. There are a lot of barriers to genetic testing. There are some families who, for example, feel since there's no current treatment available, there's no reason to get genetic testing. Some clinicians feel that way as well. It won't necessarily change anything is their mindset. And then there are financial constraints that make genetic testing difficult to access. So those are some of the barriers that we've encountered over the last 10 to 15 years about why people are not having access to genetic testing. And then we need an official count of all the people who are positively genetically tested. Now the CMDIR also does register people who have a muscle biopsy diagnosis, which is very accurate in LAMA2 CMD. So there are some countries where there's no access to genetic testing, but there is access to getting a muscle biopsy and a brain MRI and a CK level. And with those three pieces of information, you can very readily make a muscle biopsy diagnosis of LAMA2 CMD. But the bottom line is this is a moving target, and in part the reason why you're seeing very different numbers quoted is because people are basically guessing. Okay, so now we're going to switch focus and talk about the scientific meeting in Toronto. Toronto provided us with a real treat. We ended up with a blizzard on the second day of the meeting, and some people were actually trapped in Toronto. But it was a fantastic meeting. And the meeting really had two main focus areas. One was to discuss clinical outcome measures, which is basically to pose the question, if we were to run a clinical trial today with LAMA2 CMD, what measures would we use in order to see whether or not, and to measure whether a drug has had either a positive, negative, or no effect, which is the purpose of a clinical trial. Okay, and then the second area that we focused on were all of the different treatment targets that have been explored or are currently being explored, and those include targets of fibrosis, other downstream targets, protein replacement, and gene correction, and we'll go over these just in a couple of slides. Okay, so those are really the two main areas that we spent our time talking about. So I'd like to first give you an update on outcome measures. And explain this a little bit more. So as I had mentioned earlier, traditionally in Duchenne muscular dystrophy, one of the key endpoints that are used in most clinical trials is something called a 6-minute walk test, where you assess how far an individual can walk in 6 minutes. And as I had referenced earlier, while this may work for patients or people who have a partial mutation in LAMA2 and are still able to walk, the majority of people with LAMA2 CMD are not able to walk, and thus we really need to start to explore what other endpoints are relevant to the community, meaning they actually matter to that individual, and that where we can accurately measure change over time. So the best endpoint measures are endpoints that change consistently across an entire population over the time course of 12 months to 18 months. And why do I say that? That's because a typical clinical trial takes 12 to 18 months. And so in the most ideal of scenarios, you pick some kind of an endpoint, and you say how much does that change over 1 year's time, and if you can measure a decline over 1 year in a certain age group consistently, then that becomes a really great endpoint for future clinical trials. Okay, so some of the things, as many of you know, Cure CMD co-funded the 5-year natural history study at the NIH that was co-led with Dr. Bonham, myself, and Dr. Katie Nayer. And we assessed a multitude of different endpoints and outcome measures because we wanted to really see, can we measure these things reliably in people with LAMA2 CMD and collagen 6, and then how much do they change annually over a time of 3 years where they were consistently measured in the same people. So some of the things that we looked at were upper extremity functions. That means basically arm function. As many of you know, arm function is relatively preserved in people with LAMA2 CMD, but over time, as a result of contractures and increasing weakness, arm strength becomes more limited. And one of the challenges about using this in a clinical trial is that you have to measure both contractures and strength, and distinguishing between these two can be very challenging. Another thing that was measured was this motor function score, the MFM32, which is a scale that has been well validated across multiple different forms of neuromuscular disease, and it measures different things like how well you can achieve sitting, how well you can get into a sitting position, how well you can move your arms. So it's looking not just at arms or legs in isolation, but total body function. We also assessed weight over time, respiratory function, including breathing capacity, and I'll talk about this other dynamic MRI in just a moment. Looked at muscle MRI and changes on muscle MRI, and then there was also a serum and urine biomarker component to look at whether there are things that you can measure in the blood that change over time that can give us a signal. So if we were, for example, to introduce a drug or an intervention, we would see a change in that signal. Okay, so this was a 5-year study that was performed, and the data is still currently being analyzed. So our next steps in terms of outcome measures for LAMA2 CMD is to complete the analysis of this 5-year natural history study. There's a lot of data to see what actually stands out in terms of what changes on an annual basis. And then one of the other ideas that we've put forth that we are currently working on with a pediatric neurologist from the Mayo Clinic is to see if we could actually put together a natural history study that assesses kids between the age of infancy and age 5 years. Because the NIH study assessed people age 5 and older. And as we all know, one of the ideas would be to try to intervene earlier. And so what we don't currently have are good endpoints to assess strength in infants and toddlers with LAMA2 CMD. So there is a proposal that is currently being drafted that will be submitted to a government funding agency to see whether we can actually get this funded. So stay tuned for that. And then there is ongoing analysis both in mouse models, and this is being performed in Dr. Gergenrath and Dr. Derbege's lab to assess biomarkers. And there has also been human data collected through the NIH study. And then finally, there are currently 2 clinical trials, or one is a clinical trial, one is a clinical study that are in process and or wrapping up. And we hope that these 2 clinical studies are going to provide us with additional data to determine how much breathing capacity changes over time, because we think breathing capacity may be one endpoint that does change on a yearly basis that could potentially be used to see whether a drug is having an impact. So the bottom line is we still don't have one single test that with confidence we can measure in a person and say this is a consistent and valid measure. And this becomes a challenge when you're trying to design a clinical trial. So now we're going to switch gears and talk about treatment targets. So these are different areas of scientific study that have focused on how can we improve the situation in a mouse model. And the reason why I stress mouse model is, as many of you may know, there have been studies in the Duchenne mouse model for over 20 to 30 years. And while there's a lot of excitement in Duchenne muscular dystrophy now with many clinical trials, we still currently have only one treatment, which is prednisone in Duchenne muscular dystrophy, and also a heart treatment to prevent the progression of heart disease in Duchenne muscular dystrophy. And this is important to realize because not all positive experiments in the mouse model translate into a positive effect in a human being, which is the whole reason why we have to run clinical trials to see whether what we see in the mouse actually does translate into something that works in a human being. So the first area that has received a lot of attention is the idea of targeting fibrosis. On the top part of the slide, you're going to see two muscle biopsies, and on the right is a muscle biopsy where the muscle is not affected. And you can see that all of the muscle cells have the same shape, and they're tightly stuck to one another with no space in between them. If you contrast that with a muscle biopsy of somebody with muscular dystrophy, you will see, in fact, that there is a lot of pink stuff in between the cells. And this pink stuff is scar tissue that has arisen because the muscle cells have degenerated or died. And there has been, although the muscle has attempted to recreate new muscle cells, it hasn't been able to keep up. And so there are a lot of spaces where there are no longer muscle cells, and those spaces get taken up with scar tissue. So 3 different laboratories, Dr. Rug in Switzerland, Dr. Gergenrath in Boston, and Dr. Nevo in Israel have performed studies using an anti-fibrotic drug called losartan in 2 different mouse models of LAMA2 CMD. And while they did not assess survival, they did show that giving the same dose that they used in all 3 laboratories of losartan did improve the appearance of the muscle when they looked at the muscle under the microscope. It did improve the strength of the muscle. However, there was little change in weight, and as I've already stated, survival was not assessed. So this has led to a significant amount of excitement in the community about a potential clinical trial with losartan. However, there are some reasons why I think that a clinical trial with losartan will be difficult to get off the ground. First, the dose that was used in the mice is much higher when you calculate an equivalent human dosage. So it may be difficult to achieve the same level of dosage in a human being that they achieved in the mice. The second issue is that the drug is currently a generic drug. And because this drug is now a generic drug, there is no pharmaceutical company that would make a profit off of running a losartan clinical trial in LAMA2 CMD. So the only way to really put forward a clinical trial is to either bring in funding from government agencies and or advocacy groups. And we think that the effect that one can see in the mouse model, while it is present and it reaches significance, may be more of a smaller effect size, and so it may be challenging to measure a significant change over the time course of 12 to 18 months in human beings. Okay? So some people in the community have decided with their doctor's assistance and their doctor's blessing to initiate losartan in their child, or if they're an older affected individual, they've made the decision themselves. And so one of the things that we discussed at this scientific meeting is whether it makes sense for us to develop an informal protocol for those people who would like to try going on losartan, and a means of collecting data over time on those individuals, so that even if no clinical trial is run, one would at least have a body of data that was not collected in a scientifically rigorous way, but that would allow people to make a decision about whether or not this is something they want to try.
Have there been any early reports from people who have started testing this themselves of any change?
I think the two people that I know of who have started losartan, there has definitely not been any negative effects. So that's one positive thing. I mean, we always as parents are thinking about, well, tell me the positives, but we have to also remember that drugs could have potentially a negative effect. So far, no negative effects that they've noticed, and very kind of anecdotal evidence of maybe increased truncal strength. But again, because this hasn't been put to a kind of scientific clinical trial, there's nothing that we can really point our finger to say, well, maybe the kid didn't get sick as often this year, or maybe the kid was able to right themselves in the wheelchair a little bit better. But that's all very anecdotal. So that's part of the reason why with Dr. Nevo, whose name is right here, I had discussed that potentially with Dr. Nevo and Dr. Cohn, we could put together a very limited amount of data that could be collected on people who are interested, and we're going to do this anyway, and determine, you know, what does the weight of the child look like over time, what is their breathing capacity over time, how often have they gotten sick in the last year, very simple things that a parent could easily answer with some, you know, knowledge that they were needing to collect this data. And then that could be trended over time just to provide people with feedback who might be interested in starting it, as well as the dose that was used and the age that it was started.
If someone was to go on losartan, would it not let them go into other clinical trials because it would like throw off the numbers or anything?
That's a great question. So it is what for a future clinical trial, that person would have to go off losartan then, because you're right, it would confound the data set if there was some people who were on losartan and some people who. So that would be the other thing that one would have to take into consideration if one were to start it. Would you then need to stop it? And the answer is yes. And the question is, how much in advance of going into a clinical trial would you have to stop it? And that would be a variable answer. I couldn't give you an exact answer, but you know, probably somewhere between like 6 months in advance you'd stop the losartan, and then you could, you know, telling the people that who are running the clinical trial, my child was on losartan, but we stopped it 6 months prior. Will that make them still eligible for this clinical trial?
Do we have a sense for how long people have been trying losartan?
I think it's relatively new. I think the people that I know who are on it have been on it for about 12 months.
And are they typically older kids?
One is a younger child who is now, I think, 3 years old, but maybe started at age 2, and one is a older child who is age 8 when she started.
Okay.
And losartan, just for you all to know, is a drug that is used in pediatrics for high blood pressure. So there is pediatric dosing knowledge available, but again, just to be very clear, the dose used in the mice may not be the same as the pediatric dose of losartan. Okay.
Do you know what the range of dosage is?
What's that?
The range of dosage, do we have a sense for that?
Yeah, the issue with the range of dosage, and I don't know in terms of the individuals who are currently on losartan if they are all on the same dosage. In pediatrics, as many of you know, everything is weight-based, right? So it's all in milligrams per kilogram. So it'd be very easy to figure out, let's say one person is taking, I'm just going to make up a number, 50 milligrams, and another one is taking 25 milligrams, and then if you divide it by their weight in kilograms, then you would get a mg per kg dose. So you could very easily compare the dosages that people are on. And this is the kind of thing that I think would be very helpful for us to collect information on, and we could easily set up a kind of central collection data point through the CMDIR, and then report back to the community in a very unbiased way. This is the data we've collected. These are the total numbers of people who are on losartan. This is the current dosage that they are taking. This is the age at which they started it. This is how long they've been on it. These are their reported negative effects and the reported potential beneficial effects, and everybody would have to take this with a grain of salt, realizing that this is not an official clinical trial.
Of course. And we're involved in the Facebook page for communicating amongst other people with LAMA2. Is there another form of online community that's the best way to communicate, or directly to cmd.org, or how do you recommend?
Yep. So there are two Facebook pages that I would keep updated with, and that's the LAMA2 CMD Facebook page, and then there's a Cure CMD Facebook page. And anything that would be posted on the Cure CMD Facebook page would also be posted on the LAMA2 CMD Facebook page. Rachel, who's on the line here today, ensures that the information is disseminated. And then what we often do is whenever there's any kind of chunk of data to we will send a blast out to everybody who's registered as well to try and hit as many people as possible and make sure everybody has received the information they need.
Well, my only thought on this is, my biggest concern with our daughter's 20 months old, and obviously she's quite young to do any kind of drug testing on her, but my thought with LAMA2 has always been that at some point in time there may be a cure for this, especially with CRISPR and all the excitement around that. But would a drug like this be something that could help, I guess, maintain, in theory, a better condition of muscle, so that if they say in 10 years' time, in maybe best case scenario, 10 years' time, if a cure comes out, that the fact that you've been able to maintain muscle better up until that point in time gives you a better chance of a greater quality of life after that point if a cure was to come out? So like my concern has always been that muscle degradation over time, even if a cure comes and that cure gets applied, the fact that you've lived with this disease for 10 years and had that degradation is going to mean that even after a cure you are going to have a really difficult time with the condition of your muscle moving forward.
Yep. So I think that's a very that's the right way to think about this. So basically everybody has to work as hard as they can to optimize the health of their child, or if you're an affected individual and are listening to this and you're older, to optimize your own health. So far we know from a kind of medical perspective that the key things that help optimize health are maintaining a certain weight gain during periods of growth. That doesn't mean that we would like people to have a normal weight, because people with LAMA2 CMD typically may not weigh the same as somebody else who does not have LAMA2 CMD. But during periods of growth, there should be a weight gain. And if there is no weight gain, then that needs to be addressed either through tackling the amount of calorie intake, constipation, and assessing the degree of constipation, and then there's always the potential for placement of a G-tube. So that's one thing, one way to optimize health. The second is careful assessments of breathing capacity, and really thinking about the contractures that develop in the chest wall, and we will soon find out whether or not hyperinflation exercises with apoptosis provide any stabilization of breathing capacity. There is data out of France using a different machine that using a IPPV machine can stabilize forced vital capacity or breathing capacity in individuals with LAMA2 CMD. And if you can stabilize breathing capacity and maintain a greater lung capacity, that will potentially reduce the number of chest infections and also stabilize your overall breathing health. And with that, you also potentially qualify for longer for clinical trials, because the cutoffs that may be used for deciding who is eligible will be based on your forced vital capacity. And then the third thing to think about is exactly as you've pointed out. So the other thing would be to consider, is there any drug or other intervention, whether it's swimming or a medication, that might in fact stabilize the muscle condition over time.
Which this drug seems to show some signs of doing.
It shows it in the mouse model, and then the question will be whether that translates into something in a human being. So I'm not trying to be evasive here, but I think...
No, that was a good answer. That was fine.
Yeah, okay. And Ronnie, if you have any thoughts on this as well, please feel free to jump in, or Jody, yourself as well. If you'd like to add anything, feel free to give your input too.
I think you have answered everything the same way I would have answered. So otherwise I would have jumped in, I think.
Great. Okay, great.
Yeah, and you did a great job at explaining that. Absolutely.
Okay, so moving along, another target for fibrosis is a drug that's been around for quite a while. It is currently, the patent on it is held by Terex Pharmaceuticals with a license, and they are currently sponsoring additional study in Dr. Gergenrath's laboratory, and this drug is called ANG17. And there is some preliminary data from Dr. Gergenrath's laboratory in Boston, where she has already done a lot of work in losartan looking at this drug that shows a similar degree of improvement in muscle strength and muscle appearance. We should in the next 6 months have additional data on this compound ANG17 from Dr. Gergenrath's laboratory. And Terex Pharmaceuticals is assisting us in putting together the application for this natural history study to get a better sense of how things change in infants and toddlers. Because as I think this is Mark now from who's been on the line and asking some of the questions, that the earlier you would potentially intervene for fibrosis, potentially the larger effect size you could measure. And so they have been very interested in assisting Cure CMD and Dr. Selson from the Mayo to put together this proposal.
This is the same company that got the orphan drug designation for the TXA127.
You got it. And that's the same drug. It's ANG17 or TXA127.
Okay.
Mm-hmm. Okay.
And they're about to start clinical trials for that.
They are about to start clinical trials for that in Duchenne. But I think they are lacking some funding, and that's been the holdup for them in Duchenne. And the other issue...
But in February there was an article about them getting it for LAMA2, wasn't there?
That's correct. So they now have, they've pursued the orphan drug designation, and they are funding additional work in Dr. Gergenrath's laboratory in order to have additional data to look at how big the effect size is. So for example, the first data set that came out of Dr. Gergenrath's laboratory for this drug basically treated the mice over a short time course and then just looked at the muscle histology and muscle strength. Now she's completing studies where she's testing the mice, treating them both early and late, and looking at survival as well to determine whether the drug actually prolongs survival. Because really, honestly, for a drug to be taken into clinical trial, you want to see that it has a significant impact on survival and not just on how nice the muscle looks and how strong the muscle looks.
And so, are they struggling for funding for this as well? Like,
that funding, the Terex Pharmaceuticals has put together the funding to support Dr. Gergenrath. There may be a small funding gap that needs to be completed because Dr. Gergenrath is switching for her laboratory to a different institution. And so there may be some additional funding needs there just in order to support the movement of her colony. And that's something that we need to explore with them. So the next treatment target is apoptosis, which is basically cell death. So I have a nice little picture up here of what supposedly is a normal cell and then a cell that is slowly committing cell death or apoptosis. And that is the primary target of the drug imigapil. And as many of you heard, who joined the call earlier, Jody Wolf is on the line, and she's with Santhera Pharmaceuticals, and we're happy to have her on the line today. I'll just give you a very brief update on what's going on there, and then maybe Jody can fill in any of the blanks that I have not touched upon. So this is a pharmacokinetic study that is being run at the NIH, and it is testing imigapil in 2 different forms of CMD, LAMA2 CMD and collagen 6 CMD. And the very good news is that we were able to meet enrollment targets, which means that they were able to enroll the total number of individuals who met the inclusion criteria. And this was no small feat because at the same time the hyperinsufflation trial was running. And so I think it was really a great sign from our community of the degree to which people are willing to step up to the plate and enroll in studies, that we were able to meet enrollment targets simultaneously for 2 different studies in CMD. The good news about this PK study is it is basically designed to answer the question of, number one, is Amigapill safe in children with CMD? Is it well tolerated in children with CMD? And then they are also measuring trends in certain outcome measures. So the question will be, are there any positive trends? Are there any changes in the outcome measures that are being measured? And again, this will also help validate those outcome measures to say, are these outcome measures something that can be consistently measured in people with CMD? They currently, it's a 3-phase study. They have 3 different groups that they're taking through the study at 3 different drug dosage levels. And I believe they're currently enrolling the second group. This PK study, which again is a pharmacokinetic study, so it is not the ultimate trial to answer the question of does Amigapill work. It is the study to answer the question, what is the correct dosage to use of Amigapill, what is safe, well tolerated, and what may potentially support a trend in a positive direction in an outcome measure. That's what this study is attempting to answer. There will still then need to be a follow-up, what we call pivotal clinical trial, in which the drug is tested to determine whether it actually does show a benefit. So let me stop there, and Jody, I would love if you have any additional statements you would like to make about the Amigapill PK study to share with the community.
Well, I don't actually have any additional data or anything to add. I think you covered it really well, and thank you for stressing that this is a phase 1 trial, and it's really just to look at doses and safety right now, and to help provide the foundational knowledge that we need to take this into a larger trial to assess efficacy. And obviously, I mean, it enrolled pretty quickly, and we just want to thank Cure CMD and all the families that are a part of the trial. It's going really well at this point. We've enrolled the first group. We're starting to dose the second group, and of course, we'll work with you, Anna, to provide the community with updates as we have them.
Great. Jody, and thanks again for joining the call today. Does anybody have any questions about the Amigapill PK study?
Yeah, this is Tracy. I have a quick question. What are the age groups of the participants?
I want to say it's either 5 or 8 years on the low end, and then I want to say with up to age 15 or I don't remember, 16.
Yeah, I don't think we have anyone. I think you can enroll up to 18, but I don't think we have anyone that that old in the study.
And the reason that those numbers were chosen is because, you know, based on the 5-year study that the NIH had completed with Cure CMD, the natural history study, we had a good sense of what you could reliably measure between age 5 and age 18 to 20. And so the cutoff points in terms of inclusion ages were chosen based upon the knowledge of what can actually be measured in that age range.
I also just want to say that we are very interested in using as much of the data as possible from the clinical trial to help support what we know about LAMA2, and to help use that data to really enhance the rest of the field and to expedite drug development in general. So we'll be publishing quite a bit of data from that.
Okay, so moving along, we're going to talk about some downstream targets. So I just took this picture of a stream to kind of connote and just use as a symbol for what I will call downstream targets. So when we think about targets in LAMA2 CMD, the way I kind of think about any kind of treatment development portfolio is that you have targets that are not fixing the primary problem, which is a problem in the LAMA2 gene or in the laminin 211 protein. That's a primary fix. And then there are downstream fixes, which is like targeting fibrosis, apoptosis, and there's another downstream target, which is really the work of Dr. Maddie Durbridge in Sweden. And she has been working for a very long time in LAMA2 CMD, and her area of interest has been in the recycling within the cell, the muscle cell, of proteins. So there are two different processes that really help govern muscle cell growth and protein recycling. And she has just recently launched a biotech company to perform additional drug screening to identify compounds that could be tested in the LAMA2 CMD mouse model in order to see whether you inhibit autophagy or proteasome protein recycling, whether that can actually confer a benefit in terms of muscle strength, the degree of how the muscle is degenerating, and survival. She also has an interest in evaluating kind of the metabolic flavor and mitochondrial issues in this mouse model, and has recently started to focus on those types of issues in the mouse model, and has some unpublished data on that. So I think she is doing a lot of interesting work to understand some additional downstream mechanisms that might be targeted in this particular disease. And then she also has recently published a very nice study looking at both serum, which is blood, and muscle biomarkers in the mouse model over time with and without treatment, specifically treatment focused on inhibiting autophagy. So now we're going to shift gears and talk about more of a primary fix. So as you know, in this disease, laminin 211 is the protein that is either completely missing or is only partially made. And one of the early kind of primary fixes was work that was done by Dr. Marcus Rugg to look at mini-agrin. And mini-agrin is a protein that he felt when he constructed it might actually help solve the problem of a missing laminin 211 protein. So we're going to talk in a little bit about what the role of laminin 211 is in terms of what its binding partners are in the extracellular matrix. And Dr. Rugg made this mini-agrin protein to try to fix one of the lack of ability to bind. So he genetically overexpressed mini-agrin in the mouse model both early and late, and showed both an improvement in strength, muscle, and increased survival. And then Dr. Zhao Zhao, who is at UNC, was funded by the NIH to evaluate gene therapy using mini-agrin in the LAMA2 CMD mouse model, and has also shown that he is able to replicate those results using AAV or gene therapy with an improvement in strength, muscle, and increased survival in the mouse model. And then there's another scientist, Dr. Yurchenko, who's based in New Jersey, who has created a second protein construct that he calls F1. And with Dr. Rugg together, the two of them have worked together to genetically overexpress both the mini-agrin and F1. And when you overexpress both of those two proteins, you see an even greater improvement than just mini-agrin alone in the mouse model in terms of strength, muscle, weight, and survival. So let me just try to explain that a little bit better. So there are, first of all, everybody should know that there are more laminins than just laminin 211. And laminin 211 is a protein that is made and requires the LAMA2 gene to be functional. So the LAMA2 gene creates the alpha portion of this 211 protein, and this is the protein that is found outside of the muscle cell. There are other forms, though, of laminins that are made. There's laminin 411 and laminin 511, and in utero, so while the baby is inside the mother, there is actually another form that is made just while the child is present in utero, and that's called laminin 111. and this is laminin 111, I'm sure many of you have heard of, has been the work of Dr. Birkin to see if this protein could actually be made and given as a potential therapy to replace the missing laminin 211 in people with LAMA2 CMD. So there are two functions that laminin 211 mainly does, its main job. One of them is to bind to alpha-dystroglycan, and one of them is to bind to itself or to other laminins, including laminin 411, laminin 511. The mini-agrin compound or protein that Dr. Rugg has created actually helps laminins bind to alpha-dystroglycan. And the F1 construct that was developed by Dr. Yurchenko increases the likelihood that the laminins are able to bind to one another, even if laminin 211 is missing or is only partially present. So what are the next steps for mini-agrin? So one is to see whether this overexpression of the mini-agrin and the F1, if done through gene therapy, can replicate the results that Dr. Rugg achieved and Dr. Yurchenko when they overexpressed this in the mouse model. And this is going to require some funding. There are some challenges, though, when you think about introducing two viral vectors, and most people would say that trying to achieve and to inject two different protein constructs or gene constructs to lead to two different proteins would not be a commercially viable option, because most gene therapy programs are only going to try to give you one gene and not two pieces of gene genetic information that are given by two different viral vectors. The other thing is to initiate discussions about gene therapy and mini-agrin and LAMA2 CMD, and this is a real priority for Cure CMD moving forward. And then finally, Dr. Sira has actually created a mini-agrin protein, which is something that could be injected. And the question is whether with additional funding we should pursue the injection of the mini-agrin, which would not be gene therapy, into the mouse to see whether we can achieve similar results to what Dr. Rugg has achieved through gene therapy.
Will that need to be injected into each area of muscle?
Well, the thing that you would try to do is to inject it systemically. So usually the way these experiments are done initially is they inject it into the muscle of the mouse, see whether there's an improvement in the muscle, and then they go for systemic injection, meaning into a artery or vein, to see whether that can actually get to muscle, and once it gets to muscle, achieve the same degree of impact and not only improve muscle but improve survival, which is basically the same thing that they did with laminin 111, right? So it would be a very similar type of experiment to what was done with laminin 111, but just with a different protein construct. There are other proteins that potentially could help stabilize the muscle membrane. Those are galectin, laminin 111, and biglycan. And just to introduce you guys to this concept, Dr. Birkin's lab has been working on galectin and also on improving and optimizing laminin 111. Unfortunately, there are no updates on laminin 111, so as many of you may be aware, Dr. Birkin's lab really did the pioneering work on laminin 111 together with Prothelia. And then the rights to laminin 111 were in part sold to Alexion Pharmaceuticals, and this happened, I can't remember now how many years ago, I want to say 1 to 2 years ago. I have reached out to Alexion numerous times and have not received any further updates on where they currently stand, and it is unclear to me whether there potentially is an issue with production of laminin 111 versus replication of the results that were obtained in the early experiments. So unfortunately, I cannot provide you with any updates on laminin 111. And then biglycan is another protein therapeutic. This is a protein that is currently, the license is held by Tyverson Pharmaceuticals, and they currently are funding testing of this compound in Dr. Gorgenrath's laboratory. So hopefully we should have some additional data in the next 6 to 12 months on galectin and biglycan to better judge kind of the relative effect size of galectin, biglycan, miniagrin, to then come to a final conclusion of if we want to put our money into one basket and moving one particular drug forward, which is the best one to move forward based upon kind of comparative data from different labs. Alrighty, so now we are going to turn to a primary treatment target, which is CRISPR and Cas9, and this is the work that is currently being done in Dr. Cohen's laboratory. And so without further ado, I'm going to take a step back and have Dr. Cohen talk you through the work that is currently being done in his lab.
Okay, so first of all, thank you to your CMD and everyone who has been contributing to help fund this research. I'm going to try to keep this short and easy so we can go through questions. But if you look at the current slide here, gene, and the DNA is made into RNA, the building blocks of 1, 2, 3, 5, and once you have these exon building blocks together, laminin alpha 2, and you'll see this picture coming up in a little bit again. So I'm going to talk to you about this new technology called CRISPR. I heard someone else talk about it. It was the scientific breakthrough of 2015, and I used the quote from a newspaper in the UK, which called it the technology that has the potential to revolutionize the way we practice medicine. And to be quite honest, I truly believe that this is going to happen. I don't know how soon it's going to happen, but in my mid-40s, so I feel like before I retire, we will be writing prescriptions for this. That sounds a little bit more dim than it is. I'm not saying it will take 20 years, but I think we are really on our way to do some very fascinating work. So here you have a little bit of an overview what CRISPR can do. And if you want to put this in simple terms, it's really something like a scissor to your DNA. You can go to anywhere and any place in the genome and use a little bit of an enzyme, which is the Cas9 of the CRISPR. So it's called CRISPR and Cas9, and the Cas9 is really the enzyme that allows you to cut out small pieces of DNA. You can theoretically put in another piece of DNA that has the corrected version of a potential mutation, and it already has revolutionized the way how we do science. So you see on this picture, we can use this CRISPR to make cells in fish and human cells, bacterial cells, and we can now make animal models pretty much of any kind of species, not just mice, and you can do it in an expedited fashion, which has never been possible before. So people use this to make pigs and monkeys, and you can do all this in a fairly efficient way, pretty much between 4 to 6 months now. The other aspect of CRISPR is you can kind of inactivate the cutting enzyme and just use this to guide it to any gene within the genome and change the expression. So we talked earlier about downstream targets, or targets that can compensate for the loss of laminin alpha 2. So you can use this CRISPR to upregulate or downregulate genes that you know can have a positive impact in LAMA2 deficient muscular dystrophy. So let's talk now about some of the experiments we have been doing. So this is the situation in one of the animal models for congenital muscular dystrophy with a laminin alpha 2 mutation called the DY2J mice. There are several mouse models that have been generated by other laboratories. This is a mouse model that's a natural occurring mouse model that has a mutation in the laminin alpha 2 gene. And you can see that this mutation in the gene on the DNA level, if you now go from the DNA to the RNA level, you can see that it is pretty much now missing one of these building blocks of RNA. So it's missing exon 2, which then leads to a protein that is missing a significant portion of the N-terminus of the protein. So it's the end of the protein that's missing, and that's enough for these mice to be actually very, very sick. So the idea we had now is to try to develop a methodology to kind of trick the mutation into a way that instead of cutting out this exon 2, we are trying to take out pieces of DNA that would then lead to reinstitution of this exon. I know it looks like a complicated slide, but that's the theory behind our approach. So here you see that we found a potential site that if we would manipulate this with the genetic scissors, it would provide us an opportunity to trick the gene into getting all the building blocks back together. So here you see the actual scissors of where we are cutting, and we use two different, they are called guide RNAs. These are pretty much, you need to look at this as something like a car that has to go to a specific place. You put in the GPS, I want to go there, and then the car leads you to this way. And this is really what these guide RNAs do. They find a specific region in the genome, and then you use the Cas9 enzyme to cut pieces out. So, okay, here you see that cutting out this area which we identified as a potential solution would put us closer to getting the building blocks together. Okay, so we did this experiment initially in cells of these mice. So if you look under wild type, you see a faint band that has 1, 2, 3, 4, 5 exons, the way how it's supposed to be. And if you look under DY2J, you see that it's missing this block, and the band is much, much lower than in the wild type normal mouse. And here we are now using guides, clicking in. So here you see when you put either the scissor 1 or 2 together or the scissor 1 or 3 together, you get a band that is either the same size of the wild type or a little bit higher, but it is now putting the building blocks back together again, as you can see. So you go from 1, 2, 3, 4, 5, and the 3 in darker green tells you how we tricked the building blocks to get back together. So what we did then, we put these genetic scissors, which we knew worked in the muscle cells, into a vector called AV9. That's a viral vector that's currently being used for quite a number of different skeletal muscle disorders like spinal muscular atrophy or Pompe disease, and soon in Duchenne muscular dystrophy as well. And we inject this in the muscle of the DY2J mice, and you can see on the right side where it's all green lighting up, we tacked some green fluorescent protein to this just to make sure that what we inject is actually going to express, and we see that there are quite a few number of cells expressing this. So we knew that we would get these genetic scissors into the muscle of the mice, so we waited a few weeks and then looked whether we were able to restore the building blocks again. And that's exactly what happens. On the very right side you see the expression of the protein now, the wild type protein, and you can see under what's here named TAR, there you see a very faint band right there, which is showing you that we actually got expression of this protein after we cut out a certain piece of DNA and got the building blocks together. Interestingly enough, although we just injected it into the muscle, it leaked out into the liver. Now it's not surprising, and now it may sound surprising that we know this from other people who use AAV9. Even if you do a local injection, it gets all over the body. So we get quite a bit of restoration of this protein in the liver. We don't really know what it does there, and only a little bit in the muscle, but I want to tell you, as much as it looks like a really faint band, it was incredibly exciting for us to see this because it gave us we knew now that this can happen in a living organism.
I just wanted to let people know that wild type means that this is a mouse model that does not have LAMA2 CMD. So the band that you're seeing here is the band of laminin 211 basically, and that you're able to reconstitute that in the affected mouse model when injecting basically a gene therapy like an AAV with those scissors.
So what we just did a few weeks ago, we injected the same AAV9 plus the genetic scissors systemically into the mice. And what we are going to do is we are going to wait probably about 10 weeks, and we hope to see that the mice, are not going to die, and that the mice potentially can walk much better than they are walking right now. So if you take one of these mice and you look in a cage, you see that they are very, very weak and can barely walk. They actually have what's here called paralysis. So their hind limbs really don't move much at all. And we hope that with the systemic expression, we can see an improvement even of these paralysis in these mice. And so we are going to wait several weeks, and like I said, we have just started this experiment, and keep all your fingers and toes crossed that in a few weeks we have, I wouldn't say healthy mice, but at least healthier looking mice. And the last slide, and then we should discuss questions, is I told you that in addition to just cutting pieces of DNA out, we are also able to change the expression of genes, and that's exactly what we are doing. So we are trying to turn on the expression of laminin alpha-1, which has previously been shown to compensate for the loss of laminin alpha-2. And the other approach we are trying to take is we're trying to knock out or down-regulate a protein called osteopontin, which is a protein that's a gene which is known to have a lot of impact on fibrosis. So as Anna showed you earlier, we have a lot of scar tissue in the muscle, and this is a gene that can help make, hopefully, the scar tissue go away. So the advantage or the difference between the two different approaches is that what we are trying to do here by changing just the expression of this gene would be pretty much universally be applicable to everyone, independent of what kind of mutation you have, whereas the first part, where we are trying to actually fix the mutation, will be very patient-specific. So this is something which I tell you right now is keeping lots of scientists, not like myself only, but many others, busy in trying to think how we can convince regulatory bodies on one side, as well as industry to help develop sometimes drugs that will be only for one or very few patients available. So you have to have two different kind of conversations. But I can tell you, at least here in Canada, I will soon talk to the FDA in the United States as well, but at least here in Canada, our regulatory bodies clearly recognize that this is something which has to be addressed, and they will be working with us once we have enough of these data together and have enough of proof of concept studies in mice. So I'm going to stop here, and I'm happy to take questions.
Two questions, really. Some of the barriers to a lot of these testing and treatment seems to be twofold: funding and regulatory. What can we, as family members of LAMA2 afflicted people or those themselves, do on a personal level to be in action to influence our regulators and or promote funding for any of these testing?
So the last one you have already done, because Anna is specifically through CureCMD supporting all the work I've been showing you right now. And there's a lot of funding even on the federal level, not just in terms of charities and foundations going into this research. And I think from a funding perspective at the moment, my laboratory personally is in a good position, and many other laboratories are in a good position too. I think the first issue you mentioned is something which at the moment we don't need you quite yet, but I have been talking to lots and lots of parents, not just from the congenital muscular dystrophy field, but also from the Duchenne muscular dystrophy field. I hope that we have enough sound scientific evidence together. Let me be a bit optimistic here, within the next 6 to 12 months, let's say 12 months. And then when we have to start thinking about what is the real path forward to making therapies a significant portion And part of the discussion that has to help influence and kind of move regulatory bodies will be patient advocacy. So I'm counting on you and many of you on the line and off the line to help us when I reach out to you or when other organizations will reach out to you. I think what has clearly been a game changer with social media and involvement of families over the last, let's say, 3 to 5 years is that the advocacy role patients and parents can play is invaluable to me and to everyone else.
Just to add one thing to that, CureCMD organized a meeting with the FDA now several years ago where we were fortunate enough to invite a family with collagen 6 CMD and one with LAMA2 CMD to come to the FDA, to their orphan drug division, and the entire orphan drug division was invited to participate in a question and answer period around what it meant to have congenital muscular dystrophy. And so really what we first need is we need the scientific evidence that a particular intervention has good evidence that there is a big effect in the mouse model and it can be replicated. And then once we have that, as we need to then move forward into thinking about what would a clinical trial look like, we will need to have several types of meetings with the regulatory agencies. One is we can't use the 6-minute walk test. So the FDA and the regulatory agencies are going to need to be open-minded about a clinical trial design that does not use the 6-minute walk test in a muscular dystrophy. And for that, we are going to need families to step up and to explain what is meaningful in terms of their functional abilities, both from a caregiving perspective and a affected individual perspective, and what would be most meaningful to see either stabilized or changed for the better. And then the second meeting with the regulatory agencies is not just about endpoints and what matters, because believe it or not, the regulatory agencies care very much about ensuring that clinical trials are designed in a way to best answer the question of what matters in terms of how a person with the disorder feels and functions, and that it is a safe experiment to run the clinical trial. And then the second point will be that if therapies are designed that are targeting specific mutations where it becomes more like personalized medicine, that regulatory agencies will not hold the bar so high that each individual clinical trial has to go through a very high bar, because then it will really prevent us from being able to take personalized medicine to a level that is available to the entire community. And for that, families will also be needed to persuade the regulatory agencies. So as you know, these treatment targets evolve and we start to enter into conversations with the pharmaceutical sector and scientists and regulatory agencies, CureCMD will definitely be in touch. So I just wanted to end with a quick list of priorities that CureCMD has for LAMA2 CMD in the next year and a half. And then I would like to just open up to any question that anybody has. So our real priorities are, number one, to increase registration in the CMDIR. We are currently working to put together a proposal for a global free CMD genetic test that will be piloted in certain countries and will hopefully increase the number of people with congenital myopathy and congenital muscular dystrophy who have access to genetic testing. The second is the Omega Pill PK study is going to be moving towards completion, and that has been financially supported not just by CureCMD but by several nonprofits. CureCMD is looking forward to the completion of the hyperinsufflation trial. I think they just enrolled their last patient visit, and data crunching is going to move forward now. And then the completion of this CRISPR-Cas9 research project that Dr. Cohn's laboratory is working on to evaluate AAV or gene therapy using miniagrin, to put together this proposal for the infant toddler natural history study, to evaluate ongoing data that will be coming out of laboratories on the Terex compound, the Tyverson compound, and galectin, which has already been funded by outside sector, and then to look at an off-label protocol and data collection on individuals who are interested or are using losartan. So with that, let me turn over the microphone to all of you, and we would be happy to answer any questions that you might have.
When's the completion of Dr. Cohen's study meant to be?
Right now we are planning to have all of these experiments done within 2 years. I hope that for the gene correction aspect, which I showed you, where we just injected some mice systemically, that we have that in the next few months, hopefully.
It's a 2-year study that's been funded for 2 years, and I believe we are entering into our 2nd year.
Yes.
And when you say the 6-minute walking test is not relevant to LAMA2 kiddos, is that because they, even with treatment options, they will never achieve walking ability?
That's a question we don't know. Obviously, we are hopeful that some of these therapies may be able to have a huge and significant impact, but we need to be realistic enough that depending on how much damage there is in the muscle, how much of this can be reversed, specifically in older patients, is something which we simply don't know at the moment. That's why we are trying to not even have the 6-minute walk test in discussions with FDA or other regulatory bodies be a main focus point, but focus on other things. Look, if we can ever reach a result that would allow us to think about tests like this, I think we'll all be meeting for a huge celebration.
I think the other way to think about this too is that you want to have an endpoint that a person is currently somewhat able to do in order to have some kind of a baseline. And then you want to be able to show that there is an ability to improve that function that they currently are able to do. So if you think about it from the Duchenne perspective of a kid who is currently able to walk, they are using the 6-minute walk test because it's something that the child can already do, and they are looking to improve their time and distance, or their distance within that time. So we need to start with an endpoint that a typical child with LAMA2 CMD or an adult can perform, and then look at, is there a range that one can show in terms of improvement? And I think the honest answer is that we don't know what effect size we can achieve with any particular intervention, but I think given that most interventions and clinical trials will probably initially be run in kids who are older than age 5, that the degree of muscle loss in the legs may prevent us from achieving the ability to walk as an endpoint for somebody who is not able to walk at the beginning of the clinical trial.
And you're saying earlier that it is common for kids with LAMA2 to have like upper body strength. Are reach tests ever done as a metric for determining progress? Reach
tests, is that what you said?
Yeah, my daughter is not able to use her shoulders very well. She can't really lift her elbow above her chest, and I don't know if tracking the ability to reach up or reach far or...
So there's significant effort going into assessing upper body function at the NIH right now with Dr. Bannerman's group, and even within the Omega Peel trial. So that is something which gets a lot of attention and a lot of data being collected right now to see how we can best measure progress and success of any kind of therapy there.
Yeah, the upper extremity tests that are being used are things where they are actually measuring the ability, the range of motor arm, the degree of contractures, the strength, and the ability to do functional things like stack hands, which all combine this element of reach that you're referring to.
How do you explain to family and friends like how our child with LAMA2 does gain strength without having like the laminin protein? Is it because other muscles are making up the difference, or how do we actually explain that he's getting stronger in some areas but it might not last forever kind of situation?
That's a really great question, and we don't quite understand it ourselves, and it does make it more challenging. Basically, What she's asking is they have noted in their child that there are some things that their child is now able to do that their child was not able to do before. They're not sure for how long their child will be able to maintain that level of improved motor function, but there has been a slow improvement in motor function over time. And this is something that we typically see in LAMA2 CMDs. So the first 2 years tend to be somewhat challenging in some kids depending on their mutation and the degree of functional laminin 2-on-1 that they may have more issues with feeding and breathing and chest infections. And then there is a period of improvement and stability anywhere between ages 2 and ages 8, where you start to see kids being able to perform things that they weren't able to necessarily do before, whether it's better sitting control or better ability to achieve certain motor functions. And I think that part of that is, first of all, kids with neuromuscular conditions are amazing adapters. And as they get older, they realize what they can do with their limited abilities, and they optimize their ability to perform any motor function. And then I think there's also some degree where your muscle mass may actually get slightly bigger, and that there's a tipping point where that then works against you. And then I think as kids develop some contractures, they can use their contractures to provide some degree of stability to counteract the weakness that is also going on. So hopefully that provides some answers.
Is there still a bit of uncertainty around the delivery mechanism for this? I know there's been a lot of studies done around the effectiveness of actually using CRISPR, and there's been variations of CRISPR, and there's CRISPR targeting RNA, not DNA. Well, there's I think a recent study on AIDS, where HIV rather, where they were actually able to target RNA and successfully. But is there still some uncertainty around the delivery mechanism, like you were saying before, that you're able to use a viral?
Yeah, I mean, I think that's the main reason why these experiments now are moving on from cells to mouse or other animal models, to make sure that what we think the delivery for this can be is in fact true. So, I mean, I think it's going to work, and our preliminary studies and from other laboratories and other diseases show that it is possible to use these viral vectors for now, but we need to demonstrate this. So there's some uncertainty which we hopefully can eliminate over the next few months.
Personally, I wanted to thank you and other people like you researching on behalf of families with patients of LAMA2, because it is such a rare thing, and we don't know how rare, but you know, there's plenty of other diseases out there in the world that we can't find a research to even do the work. So we definitely appreciate all of your efforts.
Thank you. It's our privilege to do this.
Yeah, I'd like to second that, and I appreciate everyone's time. I could have, been scouring the web for about 3 weeks and not gotten as much information as you provided here. So it's really a very helpful update.
If any of you have ever questions in more detail, you can find my email on the web, and you are more than welcome to email me anytime.
I'll also add it to the YouTube video recording.
Thank you for that.
Okay, that would be great.
I really want to thank everybody for your very thoughtful questions and following along. It's been really helpful to actually hear the questions that you have and to interact in this way, and I hope it's been meaningful for you. I would also like to make myself available if people have any questions. Feel free to email me. And our plan will then be within the next 6 to 12 months to have another update so that we can take up where we left off here and provide you with next steps. So I wish you all a very good rest of your day or evening wherever you are, and look forward to being in touch soon.
Thank you.
And Dr. Cohen, thank you so much for your time today.
Thank you. Bye-bye.